to share a little bit about me, what I call my spheres of influence. And so these circles, they overlap, but all of these different aspects of who I am as a researcher, a scholar, really inform one another. Clinically, I started as an athletic trainer. So I have an undergraduate degree in athletic training. And then from there, I was like, oh, I'm definitely going to work in the college setting. And you know, honestly, at 22 years of age, I didn't have a whole lot of direction. I didn't really know who I was, like, or what I truly wanted to do. I was just doing what I thought I had to do. So I went and did a master's degree, worked as a graduate assistant athletic trainer at the University of Central Florida, and I got a master's degree in physical education. So after that, again, it was sort of unclear to me what I was going to do next. But I actually went and worked as a high school PE teacher and a high school athletic trainer for 3 years. And wow, that's where my eyes were opened to so many different things. So I was working at a high school. There were 2 of us as full-time athletic trainers and teachers. We were a large high school, but we really lacked a whole lot of diversity in the community that I was working. So, you know, you see low diversity, pretty higher SES families, socioeconomic status, and lots of resources, especially for things like concussion. So when I was first working as a PE teacher, as an athletic trainer, that's when concussion was really starting to be elevated, I would say scientifically, clinically, at least within this adolescent population. And so we had an abundance of resources. However, you know, right down the road in some of the other communities, again, I saw this huge disparity that I had never really seen before in terms of lower access to athletic trainers, actually no athletic trainers on the sideline for some of these schools. And it started to really make my wheels turn and think like, this is not right. We need to do something about this. So I decided to pursue a PhD, kinesiology. I worked with Dr. Tracy Crevassin at Michigan State for a couple of years, but I really wanted to focus on the adolescent population, and I wanted to focus more in health inequity and health disparity. From there, I started working and as a full-time faculty member, tenure track research position. And I realized, there's still some things that I want to be able to do that I just don't have the training and the skills to do yet. So I decided to go back to school for an MPH in public health and epidemiology. So this study is sort of one of multiple that I have done, and I really employ a health disparities a platform here. So a lot of the studies that I have out now, it's really to detect and understand. So we're understanding different patterns. So here I'm going to be sharing some stuff with emergency department data where we understand diagnosis rates and also some mechanistic differences in cause of concussion. But ultimately, all of these studies we're working to reduce these disparities. And so that's going to require different interventions and different ideas. But before we can reduce, we have to detect and understand. So this project actually developed when I was working and living in Youngstown, Ohio. So I saw this, again, this dichotomy of disparity. Youngstown, Ohio has a very high poverty rate, very working class community. And what I noticed and what I started to do, at least through the MPH program, was start to employ public health data with kind of the demographics of the people with where I'm living, working, studying, all of that. And so there is a really great resource out there called countyhealthrankings.org. And you can actually find the state that you live in, the county you live in, and you can look at a ton of different health demographics. And so what I tend to use, simply because I tend to focus more on children and adolescents, again, just from my personal and professional background, is this metric of children living in poverty. And so just looking at this statistic alone, in this graph here, we see overwhelming disparity. So 24% of children overall within Mahoning County are living in poverty. However, you can see the stark disparity between Black, Hispanic, and white populations. So I was working with the hospital there and doing some things. And so I started to use this data very strategically with a lot of the work that I was doing. So to dive specifically into this study that I'm going to be sharing today, like I said, it was part of the MPH project that I did as part of, course requirements and study requirements. But as I started to review the literature within the space, really, we saw an overwhelming amount of evidence that this data is really needed right now. So within adolescent populations, 20% of adolescents are going to receive a concussion within their lifetime, at least one concussion. However, many children who do meet consensus criteria for a concussion are not getting diagnosed in the emergency department setting. We know that the initial point of care for concussion does vary by race and ethnicity. We don't have any nationally representative data until we did this. However, with the regional-based studies that we saw and that we looked at, we saw that non-Hispanic white children were more likely to seek care for concussion in their with their primary care physician. However, non-Hispanic Black children were more likely to visit the emergency department. Now, leading causes of concussion in children and adolescents, they can include sport, and sport's the one that's getting a lot of the attention these days, but also falls, motor vehicle accidents, and assault or violence. And so here we thought it was a great opportunity to really dive deeper to understand these racial differences and mechanisms, because these differences and mechanisms can easily and do translate to differential patterns of targeted interventions. And so, for example, all 50 states and DC now have some type of concussion legislation for kids and adolescents. However, many of those laws only focus on sport. So here, I think it's a great opportunity to help to expand some of those laws to make sure kids are not falling through the cracks. So again, spanning the literature, looking at some of the mechanistic differences for TBI and concussion as far as falls, motor vehicle accidents, assault, violence, and sport, we see some different patterns here. Now we know that white children are more likely to be diagnosed with concussion and sport. However, children from minoritized groups are more likely to receive concussion diagnoses from non-sport mechanisms. As far as falls, one study we looked at by Love and colleagues, again, looking at electronic medical records, we saw that Black children had a higher fall rate, but white children had the highest TBI diagnosis rate. As far as motor vehicle accidents go, really, we didn't really see a whole lot of disparity here, and we saw that these motor vehicle accidents really are a leading cause of injury among Black and white children and adolescents. As far as assault and violence, spanning the literature, there's an overwhelming amount of evidence that demonstrates higher volumes of fatal injuries, violent injuries. Again, that can be aggravated assaults, injuries from firearms, much higher in our teenage and young Black males. Now, one of the issues with sport that I have noticed in a lot of the literature in sport-related concussion is a lot of studies are done in predominantly white communities. And so there's a lack of diversity in a lot of the published research. However, looking at concussion in sport, it has become an emergent focus over the last decade, and I think it is just exponentially growing. In particular, the sport of football really faces a lot of scrutiny due to the high velocity and contact nature of the sport. However, we see some huge sport inequity differences that I'll kind of talk about in context to the results. Now, when we look at children that actually visit the emergency department for some sport-related injuries, among children visiting the ED for sport-related injury, Black children are less likely to have a visit for a head injury and less likely to be diagnosed with a concussion. So among those children with head injury, Black children were more than 30% less likely to be diagnosed with a concussion. So because of these gaps in evidence, right, we know that there's an abundance of literature, TBI, concussion, really looking at all of these mechanistic differences independently. So to us, as we sort of embarked on this analysis, we thought it really was unclear how these mechanisms for concussion may differ by race and ethnicity. So what we did is our aims were really to look at, to determine if there were any racial ethnic differences in the proportion of children and adolescent patients seen at the emergency department for concussion, and then also to look at that in terms of any differences in mechanism of injury. We did use a publicly available data source through the Centers for Disease Control called the NAMSES, or the National Hospital Ambulatory Medical Care Survey. We used years 2010 to 2015, and we started just there simply because of the ICD code changes that took place towards the end of 2015 and into 2016. Now, NAMSES is a nationally representative sample of patients that visit the emergency department. So we have data from all geographic regions. So this is a retrospective cross-sectional design, and the study sample included children and adolescent patients less than or equal to 19 years of age that visited the emergency department. This inclusionary criteria also included those that were diagnosed with a concussion. So as far as some of the ICD codes that we use, all of the 850s that are commonly seen. However, because of some work that Dr. Mannix has actually done herself, we included the 95901 diagnosis code, which is a non-specific mild head trauma. Our primary exposure was race and ethnicity, and we used the combined and imputed race and ethnicity variable. Now, there are some limitations to using this, however, just due to either missingness at random or non-random missingness with some of the race and ethnicity variables, we decided to use the imputed variable. This imputed race variable did include the categories of non-Hispanic white, non-Hispanic Black, Hispanic, and other. So our primary outcomes, well, for aim 1, we wanted to look at concussion diagnosis. Are there any disparities or any differences between groups? And then that mechanism of injury. Now, concussion was coded as a binary variable. Either they were diagnosed or they were not. And that mechanism of injury, what we decided to use was the ICD-9 external cause of injury codes, or what we call E codes. And so those categories included sport, motor vehicle accident, fall, assault, or other accident. Our covariates included sex and socioeconomic status. Sex was defined as binary variable of male and female, and then our socioeconomic status was defined by pay status. So those categories can include private insurance, Medicare, Medicaid, self-pay, workers' comp, no charge, and other. Now, to characterize our population and to really explain, we did that by race and ethnicity and looked at all of the percentages that way. Then we examined that bivariable association between race and ethnicity and concussion diagnosis using some regressions. So I won't go into all of these details because the results are much more exciting. However, one thing that we really did is we employed some more robust statistics looking at these mechanistic differences with this multinomial logistic regression. So that was, we were able to look at 2 categorical variables in some of those distributions. Now, what's cool about this data is the findings and all results are weighted to reflect national estimates. So looking at our results here, just our table 1, breaking things down by sex, race and ethnicity, region of the United States, and our pay status. And I want to take your attention here to the race and ethnicity variable with respect to concussion diagnosis and no concussion diagnosis. So here we have the actual distribution by race and ethnicity, and we do see that non-Hispanic white children and adolescents have the highest rate of concussion diagnosis. However, if you go down and you look at the non-Hispanic Black group, we can see that non-Hispanic Black children are more likely to seek care at the emergency department or receive no concussion diagnosis. So they're going for other general medical reasons. Looking at these associations by race and ethnicity, we do see that when adjusting for sex and insurance status for SES, we see that our non-Hispanic Black children are 34% less likely to receive a concussion diagnosis. So among all groups, we can see that children and adolescents from these minoritized groups are less likely than our non-Hispanic white children to be diagnosed with a concussion. However, it was only statistically significant among non-Hispanic Black children. Here we looked at the population frequencies of concussion and mild head trauma by this mechanism of injury. And the two biggest ones here are going to be with sport and assault. And here's where we see some of these associations that were, to us, quite alarming. So among this sport category, we can see that non-Hispanic white children, more non-Hispanic white children are receiving a concussion from sport. However, when we're looking at these percentages and proportions, overwhelming number of non-Hispanic Black children are receiving or getting a concussion from an assault mechanism. So just looking at these proportional differences here, that is 3.4% among non-Hispanic white children versus 12.5% in non-Hispanic Black children. So to us, you know, we have to now make sense of these results and what does this basically mean, right? And so when compared to sport, non-Hispanic Black children are 3.8 times more likely to get a concussion from assault than sport. So to summarize sort of these main findings, falls were the leading cause of concussion among all children and adolescents, and that actually parallels a lot of the research that we were seeing. Falls truly account for a lot of head and brain trauma. Within our study, more white males were visiting the emergency room for a concussion compared to any other demographic. Now, compared to non-Hispanic white children and adolescents, the odds of Black children and adolescents being diagnosed with a concussion was 34% less. Now, me as a clinician working with this adolescent population, you know, this is quite alarming, especially because you know, being in high schools and working with a lot of high school football programs, there's a lot of diversity in youth sport. Now, there were no significant differences in mechanism of injury by race and ethnicity for motor vehicle accidents, and this actually again parallels a lot of the previous findings that we have seen. However, our main takeaway and our focus moving forward when compared to sport, assault is the leading mechanism of injury among Black and children and adolescents of the other ethnicity. Now, some of these strengths here of this study and these analyses, this is 6 years of data to provide these national estimates, and it is nationally representative sample from all geographic regions of the United States. We adjusted for socioeconomic factors, primarily insurance status. Now we know that there are limitations to doing this. However, these insurance factors may influence care-seeking behaviors. This helps provide us with clinical evidence of these mechanistic differences in concussions seen at the emergency department. It can inform future interventions. And it adds to the growing body of evidence investigating these racial and ethnic differences, specifically for concussion. Limitations of this study, we did use that imputed race and ethnicity variable. However, This is a common algorithm that we see with sort of these big databases. However, it was unclear what the other race was indicative of. Now, sport within this context of the study also included recreational sports, such as cycling and swimming. And another limitation, fall mechanisms could also include sport-related injuries. So it really just depended on the providers and how they coded things. Now, NAMSES often has a lot of missing data. There is always limitations to using these big publicly available databases. However, for this study, gratefully, there was very little missingness. Now, some implications in sort of moving forward. So big picture, what do these things mean? And for some of us in different spaces, how can we move in a different direction of helping to reduce these disparities that we see? Well, sport-related concussion, it's booming. It's an emergent focus that we see within the media, within public health, within many different spaces. Yet it may be that other mechanisms are more dangerous for Black children, as seen in the increased numbers here with assault. So these data, to me, tell us that we need to start expanding our focus from sport to other mechanisms, even in children and adolescents. Something I want to just have listeners take note of is there are a lot of sport inequities within communities in this country. So for example, I'm in the state of Alabama. I do a lot of work in high schools in the Alabama Black Belt. So on Thursday, I'll be traveling down to Selma, Alabama, because I'm working with the high school there. And football is one of 4 sports that kids at high school at Selma, Alabama have an opportunity to play. And so when there are 4 sports to choose from for males, that limits a lot of opportunity. And so thinking about these inequities in terms of, some comments I hear is, well, maybe they should play a different sport, or maybe their parents should choose something else. And that's not always so easy just because of low opportunity in some places. Now, these results can be consequences of a couple of different things, right? It can be consequences of residential segregation that we see widely within the United States. This residential segregation leads to different opportunities to do different things, including care-seeking behaviors, racial biases in healthcare, and then also systemic inequities in resources for brain injury. So for example, we see low access to athletic trainers in a lot of public high schools and communities of color. So communities of color, disproportionately, there is more poverty. When you have more poverty, less opportunity, we typically see a reduction of resources such as athletic trainers or other public health resources. We also know there are concussion knowledge disparities. And so some of the previous work that I've done with Tracy Pavassin and other colleagues looking at disparities in concussion symptom knowledge in high school kids, as well as their parents. And we see that there are differences between groups. And really, this is again related to access to public health resources, some of the concussion messaging that is provided within the state-based legislation. So these disparities in combination with these mechanistic differences is a call to provide more culturally competent educational interventions for diverse communities. So that is all I have to share as far as the study. However, I'd love to answer any questions from the audience.
Thank you so much for that talk. I think it is so incredibly important. And from the sports push, I was around in 2008, 9, 10, 11, 12. I was at the NFL when they were trying to decide whether to go ahead with heads up football. I was in a couple of insurance meetings where there were only heads of national sports organizations. And the fear at that point was liability. We're going to get sued for concussions. We got to get that information out there, and this incredible push to bring sports concussion information to parents, to transfer the liability from the sports organizations and the coaches themselves back to the parents. And how do you transfer liability? And at the time, I think if your child fell in the backyard or outside of sports, one study said you had a 50-50 chance of taking your child to for care, for a diagnosis. If you fell in a sports arena of some type, it was an 80% chance. So looking at that data, then looking at that, even makes the numbers of children brought in for assault even higher in my world, because in sports you have an organization, you have eyes on everything, you have a pressure. Your child had a hit in front of a bunch of people and people are going to ask you about it. So my thought is that even there, that number of assaults is probably a lot lower. I mean, it's probably a lot higher than those numbers of who actually gets brought in. So I think it's really important to look at this disparity. And yeah, and then in the context of this assault, and there's no, they aren't categorizing the assaults any further, whether it was within the home of a part of domestic violence or whether it was outside the home.
Yeah, not with these E-codes that we use. No.
And we tracked concussions in a school district for the last 5 years with 11,000 kids, K through 12. We had all the same, because I was working with the CDC to set it up, but we weren't allowed to use the word assault. The school didn't want to label them assaults because that would get into a whole DCF thing. So ours are coded, the assaults are coded as others, but then you can see fight as a part of it.
Yep.
So I want to take the data that you just presented and present to the schools and say, this is why it's important to have that as a categorization. So loved what you presented. I'm going to go look in the chat. Does anybody have a question that they would like to ask? I'll go to, I Hope, I saw you had a question. Do you want to ask your question?
Yeah, sure. Hello. Thank you for the presentation. That was really interesting. I really enjoyed it. I just wanted to understand a bit more about the imputed race variable and how you calculated that and what variables were used to design that algorithm.
Actually, we don't design it. The CDC does that.
Oh, okay.
Yeah. So it's already within, it's already a variable within the database. So we did not do any type of imputing or algorithm. The CDC does that.
Okay, so is there like, is there sort of a sensitivity measure of how accurate that algorithm is? Do you know? Like,
I do not have the psychometrics of that. No. However, within some of these larger databases, you do see a lot of missingness, right? And so there are some measures when you are looking at these to see like, okay, is this something that is missing at random or is this not missing at random? And a lot of times you will see that within the race and ethnicity variables. So we decided to just use the imputed one just because it was already done by the CDC.
Yeah, sure, that makes sense. Thank you so much for clarifying.
I have a question. That was a great presentation. The 959 code, which is, I think unspecified head injury. I was wondering did you look at any stratify the analysis and see to what extent one got one diagnosis versus the other by race?
I will say we did not do, well, we did actually for the study, and we didn't see any type of differences by race and ethnicity. However, when we, I was actually sharing this with Catherine, we have another sort of paper in the works where we actually just extrapolated all females. Now, when you extrapolate all females, we actually do see quite a huge disparity with that mild head trauma diagnosis. Yes.
In what direction? So like
you're more likely to see that in non-Hispanic Blacks.
Okay.
That would follow our study where there were more concussions in boys in elementary to middle school, and then high school, the girls' rate almost doubled, and that included assaults with the girls. And I think people were thinking if there were assaults at all, it would be boys.
Yeah. So, what we're seeing with some of these patterns, with some of this epidemiological data, especially from hospitals, is a lot of the providers are associating concussion with sport, right? And so we're seeing a difference in some of these diagnoses in terms of more likely to be given mild head trauma for non-sport mechanisms, even though it's the same injury. So it's sort of doing a shift and thinking of how can we even do some of this knowledge translation with our emergency department physicians, these care providers, demonstrating that concussion is not just a sport-related injury, that there are multiple mechanisms.
So the way we track it, we're working with school nurses. So we're
Okay.
getting the ER, the PD, the urgent care, the America clinics, so that you have anything that the school knows about comes through the door. It's really fascinating. So there's no pre-publishing data you can share with us about the female part?
Yes. So when we look at the assault, all I can basically tell you is that when we look at these mechanistic differences, we actually did some separate analyses extrapolating and separating concussion and mild head trauma. That diagnosis dramatically increases for assault among non-Hispanic Black females.
Yeah, it's definitely my concern.
Well, the other thing too is our research on brain injury is that, it's different in the sense that, like with adults, they have a longer recovery time or are less likely to go back to work. So everything that you learn in sports isn't necessarily transferable.
Mm-hmm.
I think there's education around that as well.
Yep. Sort of back to, again, we see these results and we have to make sense of them and think about like our messaging and our patterns. And we don't want to reinforce any type of disparity or stereotypes or anything. However, a big focus is these sport inequities. And so, again, I use Selma, Alabama as an example. And again, within this high school context, rural part of the state, girls at some of these schools only have an opportunity to participate in 3 sports. And so when you have 3 options and only a limited amount of kids can participate, that dramatically reduces opportunity for sport involvement. And so then what else is there to do? And so, as an athletic trainer, physical educator, I think exercise is medicine and sport is a good thing for kids to be participating in.
What are the 3 sports that are available for girls?
Volleyball,
Yeah.
basketball, track and field, sometimes softball.
Our highest number of concussions in our city for girls is volleyball.
Yeah. And also, so if you have less opportunity for organized sports, then you have more of a likelihood that kids are playing, what do you say, disorganized sports, but like sports in the playground, and because they don't have that, and then you have a lot of exposure there. This is really good. I love this presentation. Thank you very much. So the other area that I work in is maternal health. And as you probably are aware, the United States has one of the highest maternal mortality rates in the world. And Black women have the highest maternal mortality rate, 4 to 5 to 8 times higher than white women. And so we're doing a lot of work around healthcare bias. Because there's been a lot of work done in pain management and in a variety of areas that shows that people of color presenting with the same symptomatology often get a different diagnosis. So my other thought about the data is that healthcare bias piece, presenting to the ED with the same symptomatology dependent on race may get a different diagnosis dependent on healthcare bias, which would impact the codes because people just are, because of that bias, are not thinking the same things and are not putting down the same diagnosis.
Absolutely, 100% in agreement with that. And that's why we specifically chose to include that ICD code of 95901, simply because of the disparity we see in that use among minoritized groups. Mm-hmm.
Well, first of all, the presentation was awesome. Thank you. When what Linda had just said really I kind of look at the stuff from the DB lens. And when you talk about that diagnosis bias, and I wonder how DB plays into that because of the high risk of brain, and are they going to be more likely because of their race or ethnicity to be classified as a DB case or a not DB case? And that plays into that, is your affluent white woman going to be assumed that she necessarily is not? Oh, it can't be a DB, so she won't even get diagnosed with the, that's actually really interesting though. You guys have my wheels spinning, so thank you, I appreciate it.
Yeah, and we're really trying to be really mindful with this data that I told you, we just extrapolated females, because again, we saw the same patterns. However, that odds of assault dramatically increases among our Black females. However, making sense of this and make sure that our messaging is on point and is going to lead to the proper interventions.
What about a study where we're asking ER staff to try to get thoughts on, as people of different ages and races and mechanisms of injury come in the door?
And asking them in as far as what?
Just trying to pick up, any biases, or that's kind of segues into Josh's presentation on what the providers are looking for or thinking they're going to find and have in their head before the patient walks in the room.
So like maybe measures of implicit bias or things like that. Yeah, I think that is completely no, that's not what you're thinking.
No, absolutely. I just,
yeah,
the systemic racism, the systemic
absolutely.
Barriers of, well, people that look like this are therefore injured in this way, and then they are treated that way,
Yep.
In just the simple Black women in pain medication. The biases that exist in so clearly in this case. Linda, other thoughts?
Yeah, so New Jersey has become the second state to mandate implicit bias training for maternal healthcare providers. Problem with that is it's limited to maternal healthcare providers. Like, women don't ever see anybody else for anything else, right? And so it's a place to start. California, of course, was the first state because they always are. Yeah, California. If I could just afford to move there, I would. Trust me, I would love to get out of New Jersey and go to California. But yeah, it's a start. I actually sit on the advisory committee for the Department of Health in New Jersey that's putting together that training for New Jersey maternal health care providers. But it's limited to hospitals and FQHC. So even though it's mandating it for everybody, we don't know what everybody's going to take and what the take home is going to be. So it's a beginning. Utilizing, there's a lot of different ways. What we've been doing is utilizing the IAT, which you may be familiar with, for, the Harvard IAT for looking at implicit bias. So that could be, another way you could look at this. But this is a great presentation. Thanks for, where are you in Square? Where did you get your MPH? I missed the beginning, sorry.
So I did my PhD at Michigan State. My MPH is from Harvard. And right now I'm assistant professor at the University of Alabama in Tuscaloosa. So a lot of the work that I do is in the Alabama Black Belt, which is just the southern part of the state. And we see a great deal of health disparities rooted in systemic racism down here that we have a lot of work to reduce. And so it's a lot of work, me going to schools, a lot of school visits and boots on the ground. We have a lot of problems to overcome.
Yeah, I did my MPH at University of Michigan, so and worked at Flint, so a lot of parallels.
Yes.
A lot of parallels. Yeah.
I want to see Samara, who is presenting on systemic barriers against Black women and men with the lived experience of brain injury and rehab professionals. Are you in an opportunity where you could unmic and share your thoughts? You may not be, but calling on, yep, I got her. Pulling you into the discussion.
No worries. I really appreciated this presentation. I think for me, like I did a scoping review on care pathways for Black people experiencing a traumatic brain injury. And so like this study or like this research is really helpful in being able to kind of like have like that reference to kind of source or like more explicitly state what some conclusions that I may not have been able to because there wasn't data available to make those claims, but a lot of the literature around the statistics behind access to ER and so forth, I was able to pick up in my own review as well too. And so like as the presentation was going on, I was just like looking at the study and so I've saved it and I'm really interested in like reading a little bit more about it. But I think from my end, just silently reflecting, really agreeing a lot of creativity and thoughts around like what a study like what like research like this can do to support like my own work as a PhD student and post work too from a Canadian context. But I think that aspect around like looking at mechanisms of injury outside the context of sports is a really neglected area and something that I've really been like advocating for just over the last few years. And so I'm really happy that like there's work that's being done expressing this.
Great. So I was smiling because I actually, Samira, I have one of your papers that you have published with Stephanie Nixon up on my desktop right now. I didn't realize that was you. Your scoping review, actually.
Oh, I'm also supervised by Dr. Angela Colantonio, who really supported that scoping review as well too, who's also in the audience. So
Right.
Wanted to also acknowledge that.
Yep. All right. Yeah. So I was reading your paper before I jumped on the call today for something else.
And I really hope everybody is able to come to the PinkX event that we're having, where Wednesday, July 28th, and it's like an hour and then an hour break, then 2 hours if you just go to our event and not the whole event. So it's about 3 hours a day. Wednesday in the morning is domestic violence and TBI, IPV. The afternoon is a really deep look at the women with brain injury in the criminal justice system in prisons. And then Thursday is the same hour break, then an hour, then 2 hours on sex and gender differences. Angela will be speaking then. And then Friday will be an hour of panelists of 4 Black women sharing their lived experience of brain injury. Incredible women. And then then there's also incredible women on Thursday afternoon sharing their experience, and then Black women Friday morning, and then Black rehab professionals sharing research and their thoughts and a call to action on systemic barriers in the brain injury field. So love to have all of you there and for a part of the discussion. I did want to segue. Josh was going to present at this, but she was kind enough, and I asked her if we could push off a little bit, and hopefully she can present on Thursday at Casual Conversations. But I wanted to give you a chance to give a 10-15 minute thought on your talk. If you have to jump off at 3, I will still stay on if he wants more time.
Yeah, so that's fine. Thank you, Jessica. I thought that was so interesting, and I'm really interested as to how that plays out in the UK as well. I think that there's limited research in this area in the UK, and I think it's something that we can really learn from. So it's really interesting to hear that. So thank you. I wonder if what is probably best is I will share some of my slides, and I'll just skip through some of the background just to get to kind of the meat of the conversation around some of our new work. So I work for a charity here in the UK called the Disabilities Trust, and I'm the head of the foundation there. The Disabilities Trust works with people with acquired brain injury and autism and learning and physical disabilities across the UK. And the area or the team that I work with, we seek to consider how we could meet the needs of some of those vulnerable populations who may not be being met by current kind of provision or practice. And so we develop those kind of projects and programs which seek to kind of amplify the voices of some of the most vulnerable and consider how we can make some positive changes for them. One of those projects that we undertook was back in 2016, and it was the first study of its kind here in the UK, and the foundation of our work with brain injury and domestic abuse. And what we did was we provided a link worker service which supported the identification and the rehabilitation of female offenders whilst they were in prison. And in the project, we wanted to understand the kind of specific needs and experiences of female offenders with a brain injury. And I think there's broad acknowledgement that women's life courses experiences mean that their pathways to and through prison are substantively different to that of men, and violence and trauma and addiction often represent those life-shaping events in women's pathways to prison. And research has shown that there's that clear link between life trauma and offending and poor health outcomes for women in prison. And this was reflected in the histories of women with a brain injury that we worked with. So in this study in Drake Hall, although it wasn't specifically designed to estimate prevalence, we found that 64% of the women that we worked with in the prison had reported a history indicative of a brain injury with an alteration of consciousness or a loss of consciousness. And distressingly, 62% reported sustaining their brain injury through domestic abuse. And I think it's important to recognise that the experiences that women shared with us were histories of really intense trauma and abuse. A third of the women reported sustaining their injury prior to their first offence, with the average age of the first brain injury being at 25. And domestic abuse appeared to have an added effect to the impact of brain injury and mental health, resulting in a higher rate of mental health problems for those than those seen with just a TBI alone. I think, as is evident within these quotes, the level of trauma experienced in the lives of women with TBI was devastating. And these quotes were taken from women that we worked with and highlighted within the independent evaluation that was conducted by Royal Holloway University. And I think while these quotes are distressing to read, they importantly illustrate the extent of the adversity and severe violence victimisation for these women. I'm going to skip through this bit just because of time. However, we just to kind of update, we conducted
Josh, can you go past the hour?
Yeah.
Okay, so I could stay on, and if people have to leave at 3, but let's stay on and record, because I know a lot of people had written to me that they couldn't make this. They had end of year stuff for the school and that they wanted to watch the recording. So why don't you take the time you need? I'm available, and do the presentation you like, and then hopefully I get you back on Thursday and I'll pay for your babysitter.
Okay. Okay. So yeah, so back in 2019, we convened a round table here in London, and we gathered experts, including kind of academics and representatives from leading domestic abuse charities and the NHS. And we asked them to consider the needs of women who'd experienced domestic abuse and brain injury from their experience and where they sit within their services. And we considered how survivors could be better supported alongside gaps in awareness, research, practice and policy. And we wanted to test our findings within this roundtable and encourage deliberative debate. And we really wanted to test the soundness of this as an issue within the UK from their position. And I think what followed was a fairly lively and interesting debate and recommendations that were a product of kind of multiple minds. So the key themes that came out of that roundtable were about the complexity of causality. So we acknowledged that there are challenges in identifying the specific impacts of brain injury for those facing multiple disadvantage. So this is in part because the symptoms of brain injury were considered similar or could be considered similar in presentation to the impact of trauma or mental health or substance misuse. And so when we look at those impacts of brain injury, such as poor memory or lack of concentration, emotional dysregulation, that's a list of things that domestic abuse services told us that they often see in the survivors that they're supporting. And amongst attendees, there was a general agreement, however, that regardless of whether or not causality could be determined, those with brain injury will need additional support and adjustments compared to those without a history of brain injury. And therefore, it's still important to kind of screen and account for those for brain injury within these services. I think the debate also highlighted the importance of the screening process being as sensitive to the emotional well-being of women, alongside the importance of brain injury screening being conducted at the appropriate point within the assessment process. And as shared in the quotes earlier, many of the survivors were describing intense trauma during their disclosure of their brain injury histories, and therefore it's vital that the professionals who are receiving those disclosures are adequately trained to offer the right support following the identification of a potential brain injury. And the discussion also recognised that cognitive functioning and how well someone's brain is working directly impacts on how they're able to process the trauma in their lives. So cognitive, psychological and behavioural symptoms such as emotional dysregulation and a lack of insight could potentially cause increased vulnerability to further abuse and victimisation. And if we consider the use of personal safety planning within domestic abuse services to try and keep survivors safe, which relies on the survivor to quickly recall the safety measures and options available to them at a time of intense threat and stress, then for someone with a brain injury, that level of emotional regulation and calm action may be really challenging at that time. So following all of that work, we wanted to further consider brain injury for survivors in the community as much as in criminal justice settings. And so the following study is a continuation of this work, which seeks to understand the level of awareness of practitioners about the ways in which brain injury can manifest itself in domestic abuse survivors. So in August last year, with the support of a UK-based domestic abuse charity, Safe Lives, we launched an online domestic abuse practitioners survey to ascertain the levels of understanding considering acquired brain injury and its impacts. So we had a total of 381 domestic abuse services were invited to take part, and we had a response rate of around 26%. Respondents reported providing a range of services, so 56% were independent domestic violence advisors. Other services represented included outreach and helplines, refuges and services for children. And the majority of respondents were frontline support staff. The number of people supported each year varied significantly, with some supporting an estimated 12 and others reporting supporting up to 10,000 survivors of domestic abuse annually. I think the survey highlighted a knowledge gap around brain injury across the domestic abuse sector in the UK. So 81% of practitioners previously had not had any training or education regarding acquired brain injury. And we believe that this training and education is imperative in order to equip those practitioners with the tools necessary to ask the right questions and to understand the possible impacts and adapt their provision to meet the needs of those survivors. Nearly 2/3 of the respondents felt they were mostly unprepared to identify the symptoms of ABI, and the remainder felt they were somewhat prepared. International research kind of indicates rates of traumatic brain injury amongst survivors of around 35 to 85%. However, almost half of the respondents to our study believe that fewer than 10% of the people that they supported had a brain injury. Rates of traumatic brain injury in the UK are considered around 12%, and therefore the respondents' perception of the prevalence of brain injury in survivors is lower than that would be expected in the general population, indicating a significant underestimation of the prevalence of brain injury by practitioners in the people they support. So we also asked at any point during the contact with the people you support, do you ask them if they have any experience? And many of the respondents reported about asking common causes of brain injury, but fewer asking about any of the related impairments. Survivors.
Could you go back to that slide? The red is, I'm having
the red is the symptom was asked about, and the purple is the symptom was not asked about. So 71% were asking about strangulation, but fewer were asking about illness to the brain or concussion or a gap in previous memories.
So it's the practitioner asking the patient. Got it. Okay.
Yeah. And then this next slide is how frequently do the people you support, so the survivors, how often are they reporting symptoms or impacts of brain injury? And so they were reporting them fairly regularly in quite large proportions, including kind of hits to the head and face, being thrown against the wall, and other causes or symptoms of brain injury, which could all indicate that the survivor has a brain injury. I think the results of this study have shown us that there's an apparent disconnect between what domestic abuse practitioners believe the scale of the issue is, and in comparison to the regularity of potential causes of injuries being reported by survivors. So when we asked about gaps in provision, practitioners clearly cited to us a lack of training, a lack of knowledge and awareness about brain injury, and a lack of clarity on a care pathway about what they would do if somebody did have a brain injury. I think that shows to us that there's a need for increased awareness of brain injury and specific training and support for practitioners to ensure that there's a better understanding of the needs and difficulties brain injury could present, but also in turn to improve practitioner confidence in how to support an individual who's struggling with impaired neurofunction and deficits due to a brain injury.
That choking number is just terrifying.
Yeah, it certainly is something, and it's given us kind of a real inspiration to kind of continue to move this debate forward in the UK. And I think we really want to work together to help change the conversation around brain injury for survivors. Research in the UK is lacking into the prevalence for survivors in the community. But also we want to consider an understanding of how we can best screen for brain injury and support survivors. This further research is needed to fully appreciate the real but often hidden impacts of brain injury, to understand the prevalence of brain injuries in survivors of domestic abuse, but also to support us to understand what needs to change at both a policy and a practice level. And further research would also ensure that the significant trauma these survivors are experiencing, that they receive the most appropriate support and treatment, and that survivors can increase their self-awareness, identify their coping strategies, and be empowered to increase their well-being as they process and repair and recover from their traumatic experiences. So, as I said, we want to work together to achieve these aims, and we're now currently co-producing the next stage of our research with survivors and with support from Safe Lives, the domestic abuse charity, in order to understand the severity and impact of brain injuries alongside the interaction with other complexities such as mental health. And we feel that we must shine a spotlight on the significant trauma that these survivors are experiencing in the UK and the added impact of brain injury. And we think that this will take nuance and appreciation, and this will take engagement and collaboration from both those working in brain injury and the domestic abuse sector and beyond. But from our research, we believe it's critical for us to understand. So we need to ensure that the screening is sensitive and trauma-informed. We need to know more about the prevalence, and we need training and awareness for professionals. Our work on domestic abuse and brain injury has illustrated the trauma and the vulnerability experienced by survivors of domestic abuse. But we recognise that we're really at the beginning of the essential conversation with our colleagues across the sector to explore ways in which we can better support survivors and encourage change at all levels. And we really look forward to continuing to work together to highlight this critical issue and improve the lives of survivors with a brain injury internationally. Thank you.
I can't handle my mute. All right, I think I'm unmuted. That was such a great talk, and I appreciate your patience with allowing us to put time into the last talk. And a number of people are like, gotta go, we'll watch the video. So I see this just as a prelude to your talk on Thursday, which I really will pay for the sitters since we moved that around. But I wanted Rachel. I knew that this would just hook Rachel in. So Rachel, what question do you want to ask first?
Sorry, Catherine, I lost you a bit there.
Yeah, I know Rachel. I wanted Rachel to unmute and ask, because this is close to some research there. There she goes. Okay, Rachel. Josh.
Hi, I'm sorry. This is Rachel. I am in the car shortly home. I had a quick shift in my second job as a mom Uber. So I would not recommend it. The pay's terrible is appreciative, but thank you so much. I think so. I'm from Ohio, and we have done some I work for the statewide coalition on domestic violence in Ohio. We have done some very similar work, though more in a staff. I just would be interested in what would you be willing to share, like, what is your biggest takeaway from all of this? What do you think most like what impacted you the most? We had a lot of oh wow and holy moly moments when we were doing our work, particularly coming at it from a very from kind of a set of researchers who have very, very deep experience in domestic violence, but just really hadn't thought about it. So I'd be interested to hear about that from you.
Yeah, I think we had the same oh wow moments. It was just as you kind of start to understand and listen to survivors sharing their experiences, but also sharing the impacts of that brain injury with you, and how it's been impacting on them, but it's not being recognized or supported. You realize how vast this problem is and how much we need to kind of change and bring an awareness of these hidden impacts. I think for us, we equally had a bit of a, when we were doing the work in Drake Hall, we equally had an oh wow moment, because we had no real concept that the number would be so high of the women who had sustained their brain injury through domestic abuse. And we've had such a positive reaction and a willingness to engage from the domestic abuse sector here in the UK, who are just so keen to understand actually what this looks like for the women that they support, and the opportunity to really change or adapt their practice, which might have such a significant impact on these survivors. So I think we're really pleased to have been able to kind of forward this work here, and we're really really grateful for the connections and the partnerships we've been able to build to kind of take this forward, because I think we really see ourselves as brain injury experts, and the strength of this work will only be in our collaboration with those domestic abuse partners and stakeholders and survivors themselves as well.
Do you see the bigger barrier being, I didn't know the problem existed in the first place, or I was kind of aware of the problem, but I didn't want to poke a bear that I had no, that's not a good example. I didn't want to open a box for something that I didn't have a resource for. And, you know, I'm not set up, if I do recognize a brain injury, I don't know what the next step is, so I'd rather not open that box. Is it the initial, I didn't know that there was a box to be opened, or is I don't want to open this box because I'm afraid I don't have any follow-up care?
Initially, it has been, oh my God, we didn't think about this. We didn't know that this was an issue. We hadn't considered that this may be an issue. I think very quickly that's followed by if this is an issue, how do we deal with this? Now, you know, I don't understand how I take this forward. So I think from the practitioners and the providers that we've spoken to, it's a we didn't realize this, and then how do we deal with this? I think that everyone that we have engaged with has been willing and open and keen to think about how they can push this forward, and how they can think about what this means for their practice and their provision and support. So I think there's a real opportunity for us here in the UK to really change the way that we're engaging with this across domestic abuse provision.
Have you created any resources yet, like pamphlets or flyers? I know your stuff always looks so great. You guys have a really graphically high level of stuff. And I know Rachel has some great resources that she's produced with her team in Ohio. Are you at the point yet where you want to create a pamphlet to be handed out, or are you still at the exploratory phase?
So the next stage of our research is we're working, as I said, with survivors. So we're co-producing this next stage of the research with survivors, and we're working with some host domestic abuse providers, and we're going to use our brain injury screening index, which is our kind of 11-question clinically validated screening tool that we've developed. And we're working to adapt and alter that to make it appropriate for the domestic abuse survivors and that sector. And I think once we have an understanding of the prevalence of brain injury within the community. The next stage of that is to then start to think about the resources that we can put in place to best support them. We do have a range of, as you said, kind of our tips and tricks materials, which are available on our website. Our BISI, the Brain Injury Screening Index, is freely available to download. And there's a range of tools and materials there. They're not domestic abuse specific, and our hope is that we're able to kind of produce some specifically for survivors following this research.
Are there any other questions from the group? The tool that you just mentioned, the screening tool, is that somewhat, we have the helps tool and the modified helps tool. Was that a amalgamation, if that's the correct word? Is that a combination of other tools, or did it come from the sports space, or where did your tool, what was the origination of the tool that you are using for screening?
So we developed that tool using some standard questions that were already available in different, and we've tested that and trialed that in a range of prison establishments across the UK. As I said, it's freely available, and there's a number of research papers associated with it that you can have access to, which share its validity and helped understand the prevalence across a range of different communities in the UK.
Rachel put number 1. Rachel, who's driving, who I don't want to ask to unmic again, but I don't know what number 1 means.
No, you asked a while ago, there was like 2 options. You were like option A or option B, and I was like option A. That was from a minute ago.
You meant that I retain what I originally said and then follow out your answer.
Yes.
Any other questions you have, Rachel?
No, I just am looking forward to following up with you and talking more about kind of where we've gotten in a very similar project with domestic violence programs here in the United States.
That would be
so I will be in touch.
Yeah, that would be great.
And Josh, is there any piece of this that is looking at racial disparities, looking at some of the pieces that we were like pulling out of the earlier study that Jessica's group was looking at?
As part of the prevalence study, one of the demographics that we will look at is ethnicity. So we will look at that as one of the variables and see if there is any significance there.
Awesome. Well, I really appreciate you staying on longer, and for everybody else staying on longer. And thank you, Jessica's report was excellent, and I appreciate everybody's. Jessica, any thoughts, any last comments before we close?
No, thank you for the opportunity to be able to share with you all, and please feel free to email me, reach out if you do have any other questions, but hopefully we'll have some more work in this space coming out in the next couple of months, specifically geared towards females.
That's great. Thank you. Thank you both for your work. And thank you to everyone for coming on. I see clapping from Samara. And I do hope that you all can make the pink X. If anybody has any barriers, financial barriers to coming, let me know, because it's really important to have everybody that is has been on these calls, in that space where we'll have more time to talk. So thank you, everyone, and I will make sure to get the recording up. And if Josh and Jessica, you want to send your slide deck or partial slide deck, and I'm sure Hope will have great notes, because Hope always has great notes for us. So thank you, everyone. And this Thursday, we have a call 2 to 3 the same time, and it's Pink Concussions interns from 2016. These are girls that in high school and college were diagnosed with the time post-concussive syndrome. Were told to lie in dark rooms, and it was a very isolating time. They joined Pink Concussions for our first 2 events, and it's a 5-year class reunion, and there's weddings and PhDs and nursing degrees, and I think it'll be a very interesting time to talk to these women 5 years later to see where they see themselves and what was helpful in their, at this point, probably 10-year process to get from where they were to where they are today. So I hope you can join us for that. And then I hope Josh will be the week after if she can work out her childcare. So thank you, everybody. Appreciate the time, and please take care. Thank you.
Thank you. Bye.
Bye.